Welcome back to the Exocrine Gland Biology Podcast. Here is Juliana, and we are excited to have you with us for another episode of the second season. Today's episode is especially exciting as we will be discussing salivary gland biology and disease from both pathological and translational perspectives, with a great focus on Sjögren's disease. We are also very happy to be joined by our moderator for today's conversation, Rachel Koshar. Rachel is a DDS PhD trainee at UCLA whose research focuses on salivary gland biology with particular emphasis on how disease and cancer therapies impact gland function using single-cell and spatial approaches. She brings a strong translational and interdisciplinary perspective to this discussion, and we are grateful to have her helping us to guide the conversation today. Rachel, thank you so much for being here with us. I would love to have you briefly introducing yourself, a bit more about your work, your path, and where you are working right now.
Yeah, thanks, Juliana. You introduced me so well, but yes, I am Rachel Coulchar. I'm currently a second-year DDS PhD student with the Graduate Partnership Program, and I am getting my PhD through UCLA. And like you said, I'm studying salivary gland disorders with a particular focus on how immune checkpoint inhibitors impact the salivary glands and cause dysfunction. And I'm excited to be here today and talk to Dr. Warner and Dr. McCoy.
Dr. Sara McCoy is an assistant professor of rheumatology at the University of Wisconsin-Madison and the director of the UW Health Sjögren's Clinic. She leads clinical care and research focused on the pathogenesis of Sjögren's disease, including work on mesenchymal stromal cell immunobiology and the discovery of novel disease autoantibodies, with the ultimate aim of improving diagnosis and therapy for patients. Dr. Blake Warner, tenure track investigator and a pathology scientist who leads an integrated specialty clinic and research program that deeply characterizes salivary gland disorders from autoimmune disease like Sjögren's to immune checkpoint inhibitor sicca, using clinical phenotyping and advanced molecular approaches to inform novel therapeutic strategies. We are very happy to have you both here with us. And to get started, I'll ask you to introduce yourself better and talk about your main research focus.
I'm Sara McCoy. It's a real pleasure to be here today speaking with you. I couldn't think of a better way to start off a Wednesday morning, the middle of the week. So I start and run the UW Sjögren's Clinic, and we pull patients from a large catchment. And I really find that I learn from my patients, and it feeds right into my translational research. And I believe in trying to understand things at the bench and the importance of the bench to push forward our concepts and understanding of disease. At the same time, I leverage our findings at the bench to give right back to patients. And so I also am a site PI as well as run investigator-initiated clinical trials for my Sjögren's patients. So I really believe in this feedback, healthy cycle of my patients teach me where to study the disease at the bench, and we can bring therapeutics back to the patient. And that's the entire program I do, and it's really just Sjögren's disease that I focus on with slight digressions into radiation-induced xerostomia as it relates to the salivary gland.
So I'll introduce myself. My name is Blake. I am a pathologist scientist, an oral pathologist scientist more specifically. And I'll talk about, the fact that I came to Sjögren's because I would sit at the microscope and I would look at these salivary glands. And I would always want to know why an infiltrate, meaning the inflammation that we look at, was targeting the gland cells, the things that secrete the fluid. And I would then go back to the clinic, and I would talk to that patient the next week. And I would be, the first time I did this, I was excited, like, hey, I solved the riddle. You have Sjögren's disease. And the patients basically said, well, what can you do for me? And I had no really good answer, meaning there wasn't a drug that we knew to be effective and that would change that patient's clinical course. It wouldn't change their risk of lymphoma. It wouldn't change their risk of developing, more dry mouth or more dry eyes. And that was entirely unsatisfying to me. And it changed my life that day. I stopped studying oral cancer, which was my PhD and my postdoc. And I started working towards understanding how normal salivary glands work and how disease-affected salivary glands don't work. And then the other reason was really that use of the microscope. I fell in love with microscopes, whether it be a light microscope or an immunofluorescent microscope or a digital slide scanner, and being able to convert, information in the tissue into data, right? And we could make decisions based on that data. And so that's sort of my sort of clinical and translational research bubble in a nutshell. So I'm very excited to be here. Thank you for the warm introduction, Rachel and Juliana. I'm excited to get started.
Thanks for giving us your background and introduction. Starting off with our first question. So the salivary glands are often introduced as a really straightforward secretory organ, but clinically, when we see that they fail, the consequences are anything but simple. From your perspectives, what do you think the field fundamentally still misunderstands about salivary gland biology?
So I'll get started and then I'll yield to Blake, the expert at salivary gland biology. And I think that I'll focus on Sjögren's and what I still think are the biggest black boxes and mysteries in Sjögren's, and what I spend my time thinking about as I walk, right? That's what the great mysteries are, what you spend thinking about while you're walking from one place to another. So one of the things I cannot wrap my head around is two things. One is this discordance between symptoms of dryness and the severity objectively of dryness, because they don't correlate well. The other is the minority of Sjögren's salivary glands don't show substantial lymphocytic infiltrate, and those patients still are dry. And so another mystery that I really struggle and I think about a lot is what is going on in those patients that drives their dryness. The patients who don't have robust inflammatory infiltrate in their salivary glands and yet meet criteria for Sjögren's disease. They clearly have the disease and the features of the disease. And I think there are a lot of really good contributing factors that we know, but I don't think we understand the whole story in either of those situations as of yet. And both of those are areas of interest that I think need to be fleshed out further. But Blake, please, the gland expert.
Like, let's solve it all right here. So I agree with everything that Sara said, and I think for a lot of things we will tend to be in line. One of the things I want to put out there is that this disease we call Sjögren's is really heterogeneous, meaning there's lots of different types. And while scientifically and medically, we haven't yet defined all of those types yet because it's really tough. We're getting there, but it's really tough. It's important to understand that patients take relatively different routes to get to a diagnosis, and it takes many years. The first symptoms that patients feel or experience may be relatively non-specific and may not even involve the salivary or lacrimal glands, those organs that we think of as prototypic target organs. It may be the skin. It may be the central nervous system, meaning the brain, or the peripheral nervous system, meaning the autonomic nerves that control the organs. We just don't know. And part of that is because it's a little bit of a black box to us. We can't, we can never go back in time easily to the person's first symptoms to observe directly in the human the sort of initiating or incipient pathology, meaning like what happened at that time to that patient to sort of precipitate this very insidious yet slow progression towards the clinical state that we think of as Sjögren's disease. And there's a mechanistically we could have a 2-hour lecture, and sometimes we do, what we think of as those causes. But by and large, I think there are like three bins. One, it's a loss of function due to a loss of the actual gland itself, meaning the functional cells, the things that secrete the spit, they go away. Two, it's a communication problem. There is something, whether it be the lines have been cut for communication to the salivary glands to say, secrete fluid now. Or there are things that block the communication, whether it be antibodies or a decrease in the expression of a receptor that we just don't know that is changing that. And then I think three, there are probably what we might refer to as misclassification or genetic causes, right? That masquerade, you have some type of rare, not yet diagnosed disorder that causes dry mouth and dry eyes because of some gene, some accident somewhere. And now you either have autoimmune disease of unexplained origin, or you have a lack of physiologic function because somewhere in the sort of cascade of events that have to happen to make fluid, you lose that protein. That's an oversimplification, but I think that sort of gets at what we're going to talk about subsequently.
Thank you so much for providing that overview. I think it'd be helpful if we could go into the different pathological and mechanistic differences. I know it's still being studied and understood, but Sjögren's disease versus ICI-Sicca versus radiation-induced xerostomia, I know they have different pathology, different immune infiltrates, and then clinical presentations. It might be helpful to briefly go over those three.
I can start off with the radiation and Sjögren's, but ICI is Blake's for sure because he's so I'll let him carry on.
Really the hardest one.
Blake, it's really tough dovetailing with Blake. I would like to say I should get a gold star for taking on this challenge. So, with radiation, right, you have this initial insult, and initially there's this robust inflammation, and then actually you need these macrophages and immune cells to sort of clean up the apoptotic and necrotic mess afterwards. And ultimately what happens over time is just sheer fibrosis from damage and apoptosis, right? In contrast, Sjögren's, with what we know, is an ongoing, in many cases, especially SA-positive Sjögren's, genetically linked autoimmune process. So it's not an insult leading to downstream sequela. It is instead a smoldering fire that continues. And as Blake had already alluded to, there's usually a second hit. So there's like a predisposition of varying degrees in patients, and you'll see this clinically, right? So you have families with Sjögren's, especially males. Families with Sjögren's, and they are more likely to go on and have more severe Sjögren's and more family members. And then you have the random person who pops up and says, nobody in my family has had anything autoimmune, right? So they probably have a gentler genetic predisposition, if you will, but a stronger second hit. And what's that second hit? Again, in Blake's catchment of many things, salivary gland are viral infections and other infections. And so we think that can obviously provide a stimulus to initiate this cascade of apoptosis and downstream inflammation. And so in Sjögren's, it's really this predisposed individual of some degree, second hit, and then you get apoptosis, you get intracellular antigen exposure, and what happens is it forms sort of the Rho52 combined to human yRNA, and it forms this apoptotic bleb, and it does its work and creates a pro-inflammatory stimulatory cascade. Like I said, cellular apoptosis is promoted by this cascade, and then you ultimately get epithelial cells acting as antigen-presenting cells. And there's so many different mechanisms. Like Blake likes certain cells, I like certain cells, but every cell has a role in this mechanism, and it really is more of, instead of like a one-time traumatic event, it is an ongoing inflammatory process that ultimately might lead to fibrosis, right? And that's interesting as a concept itself, because fibrosis, in my mind, might reduce that lymphocytic infiltrate and actually might affect inflammation to some degree. I don't know if it's a protective mechanism or if it's simply a response, but that's another area I think is interesting as a digression. But Blake, take it away.
I'm glad you bring that up, because as Sara describes, right, and the way that we think about this, it's this smoldering fire, right? And I'm going to use this analogy for immune checkpoint inhibitor sicca. And I'm going to talk about that concept a little bit from the beginning, which is there was this revolution in cancer care. And really this is over the last almost 40 years, where it was in some rare patients, they spontaneously cleared their melanomas, right? And so the observation was that the immune system could clear a malignant tumor, right? In very rare individuals, this could happen. And the sort of spark was that you could engineer or re-engineer or block some type of signaling to reinitiate an anti-tumor response. Because we were starting to understand that tumors themselves, like other organs, can resist an immune insult, right? This happens all the time for viral infections. We have a robust early response, then the organ that's infected has a way to tamp that immune response down to preserve itself, right? And we call those immune checkpoints, right? They slow down the immune system. If you block an immune checkpoint, if you take the brakes off a car, you will careen down the hill, right? And in this case, careening a cytotoxic or even a T helper cell towards a tumor is ultra beneficial because the cells engage the tumor, they secrete cytokines, they secrete effector proteases, meaning things that are like little warheads to attack those tumor cells. And you hopefully, in 20 to 25% of patients, depending on the type of tumor, you clear that tumor, durable tumor response, long-term survival benefit, et cetera, et cetera. However, no good deed goes unpunished. And in this case, those monoclonal antibodies that block immune checkpoints, they are distributed throughout the body, right? And places where there might be some low level and what we call incipient inflammation, where those cells are sort of at homeostasis with their environment, whether the salivary glands, lacrimal glands, the heart, the pituitary gland, the lungs, the gut, you name it, they're probably all the kind of similar types of mechanisms. They're at homeostasis, and then you uncouple their brakes, right? You cut the brake lines, and now those cells are activated, and if they are a little bit autoreactive, they secrete high levels of cytokines, they secrete high levels of effector proteases, they damage the functional epithelium in the salivary gland. It leads to apoptosis, atrophy, and fibrosis. And then ultimately, and for whatever reason we can't understand, over some period of time, and it's usually like 10 weeks, patients wake up in the middle of the night, my mouth is dry. It's highly unusual for this type of response, but it creates a clinical scenario that looks just like Sjögren's disease, right? And so that's where rheumatology and dentists kind of work together and say, well, what is this? Oh, they're on immune checkpoints. We do the same workup that we might do for Sjögren's disease. We do the biopsy and we take a look under the microscope. And while the inflammation sometimes looks like Sjögren's, most of the time it looks like mostly that cytotoxic or T helper cell phenotype with very few B cells. And so the resultant dysfunction we think is probably mostly due to direct damage and loss of functional epithelium. That said, there's lots of different patients that come through the door with that condition, and they don't always have a loss of epithelium, so there's probably other mechanisms, but we're too early to talk about that. The second part that I wanted to say is part of using these checkpoint inhibitors is that the salivary glands and all other organs have no way to defend themselves, even if they run the programs of defense. Because the checkpoint inhibitor is there, they will just continue to have an effector function and cell restraint, so to speak. Unlike Sjögren's, where we don't know the incipient event, in ICI, we very clearly know the incipient event.
So over the last few decades, there's been the implementation of different types of technologies to better understand different types of biologies, namely single cell RNA sequencing, where we're able to see each cell on an individual basis and study them on a very deep level. And then there's also spatial transcriptomics, for example, Visium and Xenium, where we're able to see what cells are next to one another, which is really important to understand cell-to-cell interactions and communication. And the salivary glands are a great example of an organ where this type of context and spatial interaction, as well as the deep transcriptomic data, is really important to understand. And so I'm curious from your perspectives in research how single cell and spatial approaches have altered the way that we study and understand salivary gland disorders and disease, particularly in conditions like Sjögren's disease, ICI-S, sicca, and radiation-induced xerostomia that you all have experience with.
So maybe I'll jump on the grenade quickly and just give a little context. And that is to say that we throw around terms like single cell RNA sequencing and spatial transcriptomics. But for those of you in the audience that maybe haven't yet done single cell, I encourage you to go to Spotify or iTunes and look up single cell RNA sequencing podcasts. And I think one of the companies, one of the big ones that starts with the number 10, they have a whole series of podcasts on these technologies and how they work. And I think it's important to understand. So what we're talking about is being able to take one of these target organs, and whether it be the skin or the lung or a tumor itself or the salivary glands, and understanding what we used to try to do every day with the microscope, right? We used to just do stare and compare, do some histology, do some some histochemical stains, and maybe a couple use some antibodies and do some immunohistochemical. The problem is plexity, meaning how many different markers we can look at the same time. Humans, we want to reduce everything down to a 2x2 matrix because it's easy to understand, it's reductionist. But the reality that Sara talked about is that it is not 2x2. These are networks or niches of cells, and that things aren't on or off, that they sort of evolve over time, right? The disease evolves over time. It makes perfect sense that the pathology can wax and wane. And clinically, we might call that a flare, right? If we were able to capture it, we were able to capture that tissue before and after a flare, we see dramatic differences in the tissue or dramatic differences in the blood. These technologies allow us to, at a very precise level, understand, yes, the composition. What are all the cells in the gland, and how does it change compared to what we expect to find in the gland? And we can make assumptions or inferences about what are the cells that are maybe most important or least important, or even predict how cells interact based on what they express, either at the RNA or the protein level. But also it can be about what the cells are doing. What's their function, right? We can, sort of say, just like if you were going to a car dealership, you'd look at all the features of all the cars. Well, we can look at all the features of all of the cells, if they're appreciably abundant. There's 10 at least cells in the sample out of 20 or 30,000 cells. And we can we can infer what that cell is doing, and we can infer who that cell is interacting with. What we were missing with single cell is being able to look what I do every day as a pathologist is like, I want to know what that cell's doing next to that other cell, because I know that not all the cells, even though they're the same type of cells, it's an acinar cell, it's a T cell, they may not all be involved in the pathology in the same way. Spatial transcriptomics, being able to use a microscope to collect transcriptomic mRNA or proteomic protein information from the same cell, enables us to make judgments in place, right, in situ, about what 2 or 3 or 5, or maybe the gestalt of all of the cells are doing in that place. And this is where I'm going to do my own plug. Spatial biology, meaning proteomics, transcriptomics, metabolomics, is the evolution of pathology, right? And so where I found my calling as a pathologist, I always was yearning for this thing that was yet to come. That's being spatial biology. So that's my own little plug because I love it so much. But that's how I see this stuff. Now, how are we going to use this information? Well, I'm going to talk a little bit about how we're going to use this clinically, because that's the future. And I think, there's going to be a time where we have good enough analyses and pipelines where we can do spatial transcriptomics on that salivary gland biopsy or tumor, and we can see the types of interactions, and we can know that that specific interaction is druggable, and we can select a drug based on that interaction, and we can basically better predict or choose selection of targeted agents. And while in rheumatology maybe we're just a couple years behind oncology, I think there's lots of lessons that we can learn from oncology. And at some future podcast we can talk about that, the two sides of the oncology autoimmunity coin, so to speak.
As Blake is on the forefront of doing this, and I think it's the most exciting change or evolution we could hope for. And what it gets back to is what Blake was mentioning earlier, which is this highly heterogeneous disease. And what Blake is referring to is not only, tissue testing a druggable target, but then also finding unifying pathogenic endotypes, right? So this is the hot thing in Sjögren's, are finding similar groups. And we've done it in different ways in the past. But ultimately, we want to get really granular before we bring it back up into groupings. And I think spatial and single cell is going to be the way to do that. So if we can group and endotype patients by this highly granular, various cell functioning and interactions and localization of those interactions, then we can bring it back and say these patients are similar. And in their basic spatial and single cell biology, let's go back and see what their clinical phenotype is. Does it differ from the other group in any way? And so I think that it's going to be, we're working forwards into more detail, but I think ultimately we're going to group and go a little bit more broad again down the road, which is going to be, I think, really exciting. And then another neat thing about spatial that Blake taught me, and I think I think about all the time, is that gives us the opportunity to look at not only these different cells and how they interact, but how they interact based on where they are 3D, right, in the Z planes. And I think that's so interesting in something like a salivary gland, right? Or any structure where you have capsules, you have vessels, right? So the same cell can act totally differently when it's in different places. And I think that just is a really neat concept, and to have the opportunity to get down and understand that, I think it's really exciting. And I think it's a great time to be exposed to this research.
Sara uses, we talk a lot, just for the listeners, we talk a lot about this. We collaborate on lots of projects, and I'm always excited about that. But one of the things that, Sara is going to eventually show is that the pathology, and this is her term, abides, right, the molecular endotypes, right? The way that the patient presents clinically, the way that their blood profile is shown to be different across the endotypes will be reflected in the tissue. The one thing that we have not yet solved is the sort of temporal heterogeneity of the pathology of the glands and any other affected organ in Sjögren's. And I think yet again, that's another frontier for us to define as a specialty or a group of clinical scientists, is really to understand where in the disease trajectory or activity a given patient is. And our activity, I'm going to get lit up for this, but the activity scales that we have right now could be improved. It doesn't mean they're bad. It just means they could be improved.
Can of worms. It's being constantly addressed.
Constantly improved, yes.
Yes, but like all science, right? It can be done better. All science.
Yeah, I totally agree. I think that single cell and spatial technologies have really transformed the way that we can study any type of organ, specifically the salivary glands, and it lets us know what cells are interacting and what their states are, and then also where they are within the tissue and who they're interacting with. And this type of combination and synergy is really important in helping us move forward from more like was mentioning, like pathology and starting with slides, moving towards a more mechanistic and full understanding to predict and understand disease. So kind of going off of the different types of technologies and platforms we can use to study salivary gland disease. A lot of what we currently know about salivary gland biology comes from animal models or different dissociated cell systems. And these approaches have definitely taught us a lot, but they do have clear limitations in terms of physiological relevance and pathological relevance. So at a high level, what do you see as the biggest gaps or limitations of traditional models when we try to translate these findings to human salivary gland disease?
Man, and that isn't that another loaded topic. So, at Sjögren's, we have a lot of mouse models. And really, we failed to translate a lot of our therapies from mice to humans. And that, I think, also gets back at clinical heterogeneity, right? And we're addressing that now with our inclusion criteria and trials and making them more homogeneous. But ultimately, we don't have a perfect mouse model that recapitulates Sjögren's, right? So some of them get dryness, some get lymphocytic infiltrate. They have different, some are congenic models, some, are induced models. But I don't know of any that get lymphoma at the rates we get in Sjögren's, have the same sex predominance, and have the lymphocytic infiltrate and the dryness. I don't think any of them are perfect. Everybody has their favorite mouse model for what they're studying, and I think that that's reasonable, and I have my own favorites. I think also in Sjögren's mouse model work specifically, there are some hurdles and that some of the easiest mouse models to obtain have major confounders and I don't think should be used regularly in research, but are just because they're easy to get. And that needs to be, that's like, just so you know, if I review a grant and you use those mice, it's a red flag, so don't. But I think we can't get around fully. I think we're developing different modeling systems that will take into account patient heterogeneity, endotypes, and the human component of disease. However, I don't think we can fully navigate without mouse models at this point with our drug testing. You cannot recapitulate the complexity of an in vivo metabolic system. And I love playing, and Blake knows this, and he's doing it too with, microphysiologic modeling systems. I think it's exciting and it has potential, but I think right now that potential is in developing the systems. And I still use mouse work for my drug testing because I don't have something better. And I do JAK inhibitor studies, so I use a mouse model with a robust interferon signature. And that's the mouse model I choose for the drugs that I study. And I think you just have to be cognizant of your mice when you select them for your studies.
I agree with all of that. And I say this from a person that mostly looks at human tissues. And, I think this is where, there's lots of work that's done leading up to clinical trials, but also the opportunity to use clinical trials to test biological hypotheses, right? The collection of tissues from those clinical trials prospectively so that we understand where we have a candidate drug, that it does what we expect it to do, right? And I think that is something that hasn't been done uniformly in Sjögren's trials or many other trials. And I think it's something that's been adopted again in oncology. And we have an opportunity to do that as well, right? And so while I'm not answering really the animal model question, because maybe I don't have sufficient experience, or expertise to discuss that in the way that Sara does, I think the next step is, thinking about how do we ask the questions directly, right? And when I talk to a patient, justifying, the acquisition of tissue, for clinical purposes and maybe beyond. So, these are all really great questions. And I think the fact that we're having the conversation, with novel approach methodologies and limiting the amount of animals, this is something that has to happen all the time, no matter what, right? It's definitely like the 3R principles, right? We want to reduce the need, we want to replace, we want to refine. It's all very important, and it's part of what we do as clinicians, and it's part of what we do as scientists as well.
Yeah, talking about diagnosis now, From a clinical perspective, is it more common for the patients to be misdiagnosed or to take a long, complex path to get a diagnosis of Sjögren's disease? And when you think about this, how do you see, I think that's especially for Sara, you work on the novel autoantibodies, helping to move this field forward and helping to have a faster and more accurate diagnosis for these patients. And one thing that I am always curious is, what do you think it's worse for the patient, if it's getting a diagnosis that is wrong or getting this delayed diagnosis and getting too much, like a long path before getting treated?
So obviously you bring up the major quandary in our clinical care, which is it takes a long time to get these patients diagnosed. And unfortunately that leads, I think, to some mistrust in the healthcare system when you've been endorsing symptoms for a long time and everybody's a little bit dismissive. And to give anecdotes, right? Myself and many of my colleagues have some dry eye. It's pretty mild. But when I go to the optometrist and they know I do Sjögren's, have they ever brought up the possibility of Sjögren's? No, no one has, right? It just doesn't come up. And you ask your lady friends. It's more common in females, right? Perimenopausal. It's just not commonly thought of in the community. And I think that's going to shift as we develop therapies. I think there'll be a reverse education of the community about the frequency and how we need to consider it earlier. And so I think there will be some change at a community level and probably driven by patients that we should be thinking about this disease. And so I think the diagnosis frequency will improve because patients will drive the evaluation. The problem is, unlike many autoimmune diseases, the symptoms of dry eyes and dry mouth are common. Right. The primary symptom of Sjögren's, dry eyes, dry mouth, fatigue, pain, those are ubiquitous. Up to 30% of the population will have dryness at some point. And so I understand why practitioners of different kinds don't think about Sjögren's first off, because most patients with dryness don't necessarily have Sjögren's. They have another cause of their dryness. A lot of things can cause it. So these are things and barriers that I think that we will overcome, but are uniquely difficult in Sjögren's as an autoimmune disease and diagnosis. Now, the diagnosis component that both Blake and I talk about all the time, and I don't know how to simplify quite yet, is these patients who are SA negative. And one of the things we struggle with is what's the best way to diagnose them. And right now our criteria and our gold standard is a labial salivary gland biopsy. Blake does them, I do them. We both think they're very easy and that everyone should have a facility that can do these biopsies and then send them to a pathologist who's able to interpret them, which is a harder skill, I think. But it ends up being that very few people do these biopsies, and that many times you send them to a general pathologist who doesn't have a lot of experience with how to interpret them. And I'm not sure how to best navigate. And we're working on, whether other autoantibodies like anti-centromere antibody could be used in addition to SSA antibody. And these are clinical questions that we'll do more research on and try to answer, I think. But that's the struggle, is in the Rho 52, Rho 60 negative group, what serologically can we use to supplant the need for biopsy? And that's been sort of this holy grail of Sjögren's clinician diagnostics research for a long time. And so OMRF has done a really great job doing a proteome array and identifying some possible new autoantibodies. And that's been published. There's still some barriers there. And then I used a whole peptidome array to try to identify new antibodies. And we found one that was, I think, pretty interesting, but I always am tentative of any research until I validate it. So I validate it with external samples, but now I'm sending it to collaborators internationally before I say that this is in even a subset of patients able to supplant biopsy, because many people have failed. And I'm humble enough to say I'm doubtful I would have a gold standard antibody, but it's promising. I'm researching it. And right now we're developing a standard curve, and we're going to send that autoantibody testing to international collaborators who hopefully can tell us if it works in other hands as well.
So I'm going to pivot off, not pivot, but I'm going to expound upon that a little bit. I completely agree. And I sound like a broken record. But the way we use the biopsy is generally, and I'm not saying me in my clinic or Sara in her clinic, is a little improper in that, we're only reserving biopsy for the patients who are autoantibody negative, right? And sort of the problem for oral pathologists when I go to meetings and I talk about salivary gland biopsy is that they say, well, there are almost no positive biopsies. And the reason is that the only biopsies they're receiving are either A, insufficient material, or B, they're from SSA negative. And it is true that SSA negative patients on average have lower focus scores and less characteristic inflammation, but it's not zero. It's not always. And it's important to remember that there are the patients that are row 52, row 60 specificity negative with a focus score of 12 and need to be worked up for lymphoma. They exist. The second thing I want to talk about is that we really need to be able to discriminate Sjögren's disease before patients develop dry mouth and dry eyes, because I think the majority of the dry mouth and dry eyes that we see is relatively permanent, right? It reflects damage to the organ. We shouldn't be waiting around until patients are sufficiently damaged that we can measure the change, or the patient themselves can perceive the change, because part of what we do as humans is that we accommodate. And whether you, me, and I'll give an example of myself, admit this or not, we probably all have a junk drawer, right? And we stick stuff to it and it just keeps getting more full. And we accommodate to the fact that it just little by little every day just accumulates more stuff until some point we're like, oh my gosh, I've got to clean out this junk drawer. Damage in the exocrine organs, in my opinion, tends to be the same until you can perceive the difference and you have time and availability in your schedule to see the physician and get referred and you're not going to get a diagnosis. And so what does that mean? What do we need? How do we augment diagnosis? We need a biological marker that says this person is highly likely to be classified as Sjögren's. In addition to SSA, in addition to SLC70 or any other marker that has some frequency in Sjögren's, we need something that says this person's likely to develop Sjögren's before they develop these symptoms. And really, this is to stave off, in addition to what we're talking about salivary gland biology and dysfunction, is an equally important parameter, clinical feature, is the profound fatigue. And that is what patients say most disaffects their life, right? And I believe that if we can diagnose this earlier, we can initiate effective therapies earlier, a lot of these life-changing events, whether it be quality of life and health of the mouth, or whether it be overall health and quality of life, or even your basically over your ability to do daily activities of living, I think everyone will benefit, right? Earlier diagnosis, earlier initiation of effective therapies, so on and so forth. And maybe we get to the point where biopsies aren't needed. Patients don't experience salivary gland dry mouth and dry eyes. And now Sjögren's really is recognized as what it is a systemic chronic autoimmune disease that really needs to be treated before these other endpoints.
I think Blake gets to it, but that's the goal. Blake gets to what the ultimate goal is. And then that gets back to, again, right, when we have new therapies that we think are really effective at depleting certain immune cell subset populations, so Blake brings up some damage is not reversible. Is there any damage that is reversible? Do we have to catch it early enough to prevent disease? That's the proof is going to be in the therapy. That's going to be a trial that will teach us that, and we don't know yet. Those drugs are ongoing, and there are studies trying to look at damage and whether these therapies can reverse it. But you bring that up, like ideally we prevent, as Blake said, because not everything is going to be reversible. How we do that? Oh man, I think we have such struggle with diagnosis now. Early diagnosis, I think, is going to be the next frontier.
Pediatric.
Right, the pediatricians, and they're always happy to help. They're the nicest people, so that's maybe who we work with.
I didn't know that biopsy or patients that are SSA positive don't tend to get biopsies. There's like a shortage of those type of biopsies. Is it just because they're assumed to have Sjögren? So kind of going off that with developing and finding biomarkers, I think it might be interesting if there's biomarkers that have been established for some type of disorder. It might hinder the actual obtaining of glands for more like mechanistic understanding, if that makes sense. So I think that's an interesting like line to think about. Like just because Dr. Warner had mentioned that there's a kind of shortage of the biopsies, salivary glands from patients that are SSA positive. And so, yeah, that's just interesting to think about. But yes, do you have anything to say to that?
Well, Blake is getting into the niche of it, right? That's what we do as sub specialists. And Blake brought it up briefly, but it's really true, is that if they have abnormal salivary gland ultrasound or clinical swelling, we should be doing biopsies to rule out lymphoma. But I don't think that's widely adopted. And largely we see that in the centers. And so I'm not surprised, like, and I never thought about it from the pathologist perspective, but it makes so much sense.
Yeah, and the other side makes sense too, right? We should be always working, striving towards a less sort of risky evaluation, right? And while my bias is that I think minor salivary gland biopsies are very, very low risk. It is not zero risk. And if we could diagnose it better at a zero risk state, then what you're talking about really falls into the bin of clinical research and partnering with patients and having that discussion with them about the need for biopsy as a research tool, and them, agreeing, consenting, participating in the research. And that's a different thing, right? There are people that do both, right? Research in the context of clinical care, that happens, but we have to bin those frameworks separately, right? People that do clinical research, we really think about this a lot, and we want to ensure that, that we're doing the best for our clinical patients all the time, right? And for people that do clinical research, that they have to juggle both of those things. But clinical research, risks of the patient, that's first and foremost. So, our clinical care, if the salivary gland biopsy can be augmented by something else that has, that explains the variance to the same degree, then we should use that. We should adopt it, right?
So super briefly, just one quick point. Right now, it seems like the salivary gland field is really at like an inflection point where we have more access to tissues, different types of technologies, and then also better understanding of the heterogeneity of salivary gland disorders. And so knowing that, looking ahead, what do you think will be the most meaningful change in how we diagnose and treat salivary gland dysfunction within the next decade?
So I'll be simple and I'll go first. I think the institution of these large-scale therapeutics is going to massively change the landscape. I think it's going to markedly increase monetary investment in the diagnosis from an industry side. And that will then galvanize, both patients, clinicians, and researchers to put more time and effort into this disease. So I think it's sort of a chicken and egg, and now the chicken is going to drive us to investigate why this egg occurs. That'd be my guess, but it's only a guess as to where we're going to go.
I tend to agree with that. I think that one thing is, as there's more investment, as there are patients whose systemic disease activity changes, it will highlight patients. If we're going towards the salivary and lacrimal, the sicca component of Sjögren's, it'll highlight those patients that don't benefit. And we will need to think about them specifically, right? Who are the patients that don't benefit from this? And what can we do for them? What's the next strategy. And it might be something that Sara is studying, where we want to target the fibrosis or re-engineer the fibrosis to create a new environment. It might be regeneration. There's lots of work on regeneration, and that sort of even spills over into these other diseases like radiation-induced xerostomia. And if we talk about regeneration or sort of re-engineering the salivary gland, then we also have to talk about how we augment function, right? There's clinical trials out there for radiation-induced xerostomia where you augment function either through a gene therapy approach. There's ways to take out and then put back in some of that salivary gland tissue, as Sara is leading that charge right now, to regenerate the radiation-affected gland. So probably there's other strategies as well, and we don't have time to talk about all of them, but I think what Sara is saying is that as more money, more investment, more research happens, it allows us to get a better lens on where the new problems will occur.
Mm-hmm. That was an amazing discussion. And before closing, I just wanted to invite you to give an advice or a takeaway for clinicians, researchers, and early trainees. Just a phrase that you'd like to share with them so they can enter the field, or they are already in the field and they want to move forward.
Ooh, that's I don't have a one-liner, but as someone who came a little bit late to the game and didn't take a traditional career course, I find it incredibly rewarding to be able to tackle making patients' lives better in a disease where there really isn't a great therapeutic or intervention. And so on a day-to-day basis, even though I took sort of a long and painful road to get to this point, all roads are long and painful, but a tortuous one at the very least. What I would encourage is clinicians to, if they have an interest at all, to delve into the research world again, whether it's clinical research or basic research. I think it is a different way to make patients' lives better. You can see patients clinically, but also if you have an interest, you can really, I think, make a difference at the bench or with trials as well. And I think you should always think you can do it. And it's really rewarding when you get there.
Yeah, I think and I'm going to say this for one side and then the other. For the clinical side, what triggers me towards, better therapies, what wakes me up in the middle of the night, which wakes me up at 4 a.m., which keeps me up late, what keeps me excited really is this critical thinking, deep thinking about the problems that you see in the clinic, the things, the observations I make at the microscope, right? And a little bit allowing yourself to almost obsess about those things. You're allowed to do that, right? You can make choices. But it's that critical thinking and thinking through all the steps, even if you don't know all of the steps, because you aren't going to know everything. And then thinking again about who are the people who can help you, right? The mentors, the collaborators, your friends, right? And all of my colleagues become friends at my great peril, as I've been told by my mentors, but I can't help myself. And then just basically being a little bit open-minded and transparent. Like, I'm thinking about this problem. What do you think? Is it good? Is it bad? Like, have, that straw man idea to knock down, to find the better one. And the second thing for the trainees, especially the ones that are like junior trainees and they're trying to find their place in the world, the research world or whatever, it is a marathon, not a sprint. You have to find the sort of matching energy, enthusiasm, and capacity, right? And obviously, there's intellect goes into it, but really it's finding something you're really interested in and diving in, right? Figuring out what works for you, what the projects are that work for you, finding the right mentor that works for you, and just, sticking to it. If you are like me a little bit, and I'm a little scattered, sorry, for all of my clinical staff, I like a lot of new stuff, but I have to reflect and be sort of self-reflective of what is the thing I need to be doing and what is the thing I want to be doing. And obviously the wants are always greater than the needs. And I always need to sort of move things over to the want so I can complete the need. And so that's my advice for trainees is focus. I hear this all the time. Focus, 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 focus.
Everyone tells me to focus. I don't like to focus. I
don't either. But
never.
Okay, maybe I'll say it this way. This is, when you talk to people, tell them a focused story. Leave it at that. If they come back to you and they want to ask about something else, you can tell them another focused story. And if they come back after that, you can tell them another focused story. But don't tell too many focused stories that aren't all interconnected.
I like that. It's like bedtime for kids. You're only going to read them one book at bedtime. You just got to pick one book.
Exactly. As one person says, find a good story, tell them a good story, leave it at that. One's enough.
I love these advices. One of the objectives of the podcast, besides discussing science, is also showing how collaboration is important, having a good mentor, and having critical thinking to move the research forward. So I want to thank you both for being here with us today. It was a pleasure to learn from you, your expertise, and hear the work you have been doing. I also want to thank Rachel to guide the discussion with us today. If you have anything else to say, just to finalize, I am really, really grateful to have the opportunity to talk to you.
Thank you, Juliana. This was great.
Yeah, you can tell Blake and I riff all the time. It's really fun. His scientific brain is great to discuss. Well, thank you.
Bye.
Thank you so much. Bye-bye. And thank you to our listeners for following the Exocrine Gland Biology podcast. Stay with us for the next episodes. Thank you again for listening, and we will see you next time. Bye.